been trying for 6 to 12 months and have not had a pregnancy, definitely you should go see a fertility doctor. I think there's a big push to talk about male infertility now. I see a lot of women who say, well, I want to check myself out first and make sure I'm not the problem. Don't internally blame yourself, because there could be an equal chance that your partner has a concern. And there's been lots of publications showing that sperm counts have been decreasing over time. So there's a lot of anxiety surrounding infertility. And, lots of couples are like, checking when they ovulate with ovulation kits, and it's like, oh my God, now it's go time. Now we have to try. And that's a lot of pressure. The women are born with a certain number of eggs. By the time they reach menopause at the age of 50, you only have about 100 eggs left, and those probably have multiple genetic abnormalities.
Fertility is one of those things which everyone whispers about, but no one talks about it openly. Behind closed doors, couples silently carry the weight of treatments, miscarriages, and silent heartbreak. Today, I have Dr. Prati Sharma with me, who's a reproductive endocrinologist and infertility specialist at Create Fertility Clinic. She's also the president at CFAS and board member at several reproductive health foundations. She's guided families through IVF, IUI, egg freezing, miscarriages, while breaking the stigma that surrounds fertility. We're going raw today, what every man and women should know, the myths that nobody questions, and how couples can hold on to hope in their darkest chapters of their life. Hi, Dr. Sharma. Thank you so much for joining us today. We would love to hear your journey. What motivated you to take up fertility medicine? Was it science, or was it someone's story that resonated with you?
Yeah, well, thank you so much for having me on this podcast. I think you're really talking about some crucial and important issues. So what drew me to this field? Well, I started out as a medical student really interested in women's health, and I thought I was going to be an obstetrician because I thought the miracle of life and, babies being born was just so cool. But I quickly realized that, I did want to build a real bond with my patients and, as you said, guide them through this journey that involves so many highs and lows. And so yes, delivering the baby is great, but that's sort of the end point, getting pregnant and having your baby. And there's so much more before that a patient has to go through, or a woman or a family or a couple has to go through to get to that baby. And so I started exploring the other fields in women's health outside of just obstetrics. And so I looked into cancer treatment like gynecologic oncology, but that was really too sad for me. And then I thought about high-risk obstetrics, which is really specialized for OB, but I landed on reproductive endocrine and infertility because it really sort of merges cutting-edge medicine and novel therapeutic techniques with something that's so basic and so important and is a need that we all face as women, and particularly South Asian women. So it's a really nice bridge where you get to know your patients and then hopefully help them with one of the basic rights that we have, as humans.
Right, that's interesting. So if a lot of women, they take months or even years to get pregnant, or on an average, they keep trying. On an average, couples take 3.2 years before they seek medical help. So why do they delay it? And when is the right time for them to approach a fertility specialist?
Great question. So, it's not all doomsday. I think things are really changing, particularly what you're doing, speaking out loud about these common issues, normalizing infertility as a typical medical concern. I think people are identifying this as something that needs to be evaluated sooner, but there's still a stigma, right? It's supposed to happen so naturally. You want to have a baby and 12 months later you have a 3-month-old in your arms, but it's not quite like that, right? So I've been saying recently to my patients that the old definition of infertility, which is trying to conceive for 6 to 12 months without a pregnancy, we say 6 months for those over 35 and 12 months for those women under 35, that's like out the window. That's in the trash can now. Now it's all about empowerment and thinking about your family building over your lifetime. So for a couple or a patient who is interested in having 2 or 3 children, but is not ready to try right away, they can come in and get a fertility assessment very early just to do a pulse check and see if their fertility looks good. So typically we do say if you've been trying for 6 to 12 months and have not had a pregnancy, definitely you should go see a fertility doctor. But there are many other reasons to come in sooner. Let's say you've been diagnosed with a common endocrine disorder called polycystic ovary syndrome, or you clearly see that your periods are irregular, or maybe you have endometriosis or really painful periods. These are all things that can affect your reproductive health. And so coming in sooner to be evaluated makes a lot of sense. So I think family doctors and REIs like myself are really open to seeing you whenever you want. Perhaps you're single and you don't have a partner and you want to freeze your eggs. So don't think that there's a certain definition or when exactly is the right time. If you think you need it, do not delay and come in, because there's always options for you.
Right. Interesting. It's very true, though. Also, when we talk about stigma and when we say infertility, we always associate, or rather people associate that to women, while male infertility is also equally responsible in fertility issues. So how do we change this narrative? And how does that impact couple emotionally and culturally when they come to you for treatment?
I think there's a big push to talk about male infertility now, and men are really open to speaking about male sperm health, male reproductive health, and what they can do on their part to improve fertility. And that is a big conversational shift, even from the last 5 years, right? And so if you look at the data, female infertility is 30% of the issue, but male infertility is 30% of the issue. So what can we do to break down these taboos and these stigmas? Well, I think if you are in a relationship with a male partner, or if you are trying to conceive with your male partner, bring that person in for the first consult. Get him tested just as you're going through testing, because I see a lot of women who say, well, I want to check myself out first and make sure I'm not the problem. Don't internally blame yourself, because there could be an equal chance that your partner has a concern. And remember, an embryo, a viable, healthy embryo, is made up of 50% egg and 50% sperm. So I would say get the male partner involved right away. Have these conversations, even at home, if you're talking to your male partner and you're trying to conceive, even before you hit the fertility doctor's office, women are constantly like, what should I eat? What should I drink? What should I take to maximize the chances of pregnancy? But talk to your partner. What should he eat? His body weight is important, whether he exercises, if he has any toxic habits like excessive drinking or smoking or marijuana use. So really make it a we concern rather than just me.
Right. It's true. So true. Also, when we talk about, we are talking about male infertility, right? And do we see the infertility rates in male, is it increasing compared to last decade?
Yeah, I mean, there's been lots of publications showing that sperm counts have been decreasing over time. And so a lot of this is probably due to us living in the first world, modern day, lots of processed food. Obesity is on the rise. Marijuana has been legalized, and marijuana we know has an effect on sperm. So all of these things, environmental toxins, parabens, all of these things have been shown to contribute to male factor infertility. So having as clean diet as possible, eliminating toxins, being generally healthy, keeping your body in the normal BMI range, diet and exercise, all of these things contribute. And so, we're surrounded by modern day society, but we have to remember, what can we do to make sure that our body and our health is optimized when we're trying to conceive? And this goes for both men and women.
So the lifestyle changes play an important role.
100%.
Understood. Also, when we talk about male infertility, does erectile dysfunction one of the earliest signs?
So erectile dysfunction is a common concern with fertility patients.
Right.
And I think that's for a couple of reasons. One is there could be an organic cause. If you have male factor infertility, perhaps have low testosterone, are overweight, maybe drinking alcohol or smoking, that can affect the function of your reproductive tract. But also there's a lot of anxiety surrounding infertility. And, lots of couples are checking when they ovulate with ovulation kits, and it's oh my God, now it's go time. Now we have to try. And that's a lot of pressure, right? So a lot of men will experience ejaculatory dysfunction and erectile dysfunction when they're around that ovulatory window, and it's sort of that pressure to perform. And age is also a factor. As men get older, they are going to have more concerns with ejaculatory dysfunction, erectile dysfunction. And so I see a lot of that in my practice as well. And sometimes it's a combination. So there might be some degree of ED, but there might also be vaginismus in the woman. So the woman might have difficulty with intercourse. And so that combination is infertility in and of itself. If you're not actually having intercourse appropriately and ejaculation is not happening at the fertile window, then you're not going to be pregnant. So there's lots of ways around this. I mean, certainly addressing the root cause and sort of fixing the ED and helping with the vaginismus. Sometimes psychotherapy, vaginal dilators, all those things can help. But in our clinic, we can do intrauterine insemination or IUI, and sometimes that just takes the pressure off. So the male can produce a sperm sample, the woman can have an IUI in sort of a non-pressured situation. And so sometimes that's what works. So there are lots of avenues to treat this. So I wouldn't sort of hide behind closed doors and think, oh my gosh, it's just not happening. Be open, speak to your doctor, and there's ways around.
Right. Also, there are a lot of supplements that are available in the market which claim to boost sperms or sperm count.
Yeah.
So is there any evidence behind that, or is it just the marketing gimmick?
No, I mean, I think supplements are a bit of a black box, right? And it's kind of like social media. You can read so many things, or Dr. Google, right, about what's good, what's not. But there is evidence that supports certain supplements. And so when we talk about supplements for sperm and even egg health, there are certain antioxidants that are good for sperm quality. I'm personally an advisor to a company called Bird and Bee, and we make a sperm health supplement. It's called the Powers for Males. And it has all the antioxidants that have been shown to improve sperm motility, sperm morphology, sperm parameters by 30%. As I tell my patients, this is not a magical cure, right? You can't still be smoking marijuana and cigarettes and then hope that the supplements will make things better. They're not going to reverse severe oligospermia, which is very, very low sperm counts. You still need a fertility doctor or potentially a urologist, an IUI or IVF, but certainly they can boost the quality of the sperm and potentially make your IUI or IVF success rate higher.
Right. So there are a lot of other factors. It's not a magic cure. Right. Also, we spoke about egg freezing, right? So is there an awareness about sperm freezing? And is it only for men who are going through medical conditions like cancer, or even a healthy male can go about with it?
Yeah, it's such an interesting question that you touch upon. So yes, egg freezing is based on the phenomenon that women's eggs age over the age of 30 and they accelerate over the age of 35 and especially over 40. And so now we have this incredible way of doing IVF and freezing eggs at younger ages, and you can utilize those eggs later. And this is all due to chromosomal aneuploidies or abnormal genetics of the egg, right? And so, yes, great. Women should freeze their eggs young if they're not getting pregnant. Men are a little bit different. So we don't really see a significant decline in sperm quality until really over 50, maybe over 45, or as you said, if there's some sort of medical condition. So there's no recommendation per se to freeze your sperm. And sperm production continues even after death, like for a little bit. So it's not like women where they go into menopause at the age of 50 and they're perimenopausal between 40 and 50 and their egg quality drops. Men are very virulent or virile between 40 and even up to 50, 55, 60. So again, there's nothing that says men should freeze their sperm due to aging, but recently we've been seeing data that supports that there is a tendency, it's not 100% or anything like that, but there's a tendency towards increased mental health issues, autism with men of advanced paternal age, so men over 40. So is that a soft call indication for men to freeze their sperm if they're not getting pregnant when they're under 40? Again, no strict indication, but freezing sperm is way easier than freezing eggs. So in theory, yeah, so why not? I would probably advocate and say more than sperm freezing, I think it's probably good for a man to have a fertility check, to do a semen analysis early on just to see if anything's going on, because women have a lot more outward symptoms. They have menses, and if they're irregular or if they're painful, that can indicate a problem, but men don't necessarily have as many outward symptoms when it comes to lower sperm quality. So the only way you can check is to do a semen analysis.
Right. Fair enough. Also, when we've been talking about PCOS, PCOD. So people often get confused. It's used interchangeably, PCOS and PCOD. So how different is that? And how does that affect a couple who's trying, or more so women who's trying to conceive?
Yes. So, very common diagnosis, probably affects upwards of 15% of the reproductive health population, particularly more common in South Asians. The name is a bit of a disaster because it is really truly a misnomer. So, polycystic ovary syndrome or polycystic ovary diagnosis, the big part of this is polycystic.
Right.
And that's actually not correct. So, women come in all the time saying, I've been told I have a number of ovarian cysts. But the cysts that are being referred to as cysts are actually multiple ovarian follicles or eggs. And the issue is what we call chronic irregular ovulation, oligomenorrhea, or anovulation, which is not ovulating. And so this is cycles that are longer than 35 days apart. Sometimes women are anovulatory.
Right.
They don't get periods at all. So an ovulatory disorder, so you're not ovulating, a high antral follicle count. So whereas normal women in their 30s have an egg count, let's say, of like 10 to 20 follicles in their ovary, women with PCOS are starting at 12 in each ovary. So it's like 12 upwards of 30 eggs in each ovary. And they're peripherally located. There's an increase in centralized stroma, which is what creates all the male hormones. So this is the second piece of PCOS, hyperandrogenism or high male hormones and clinical or laboratory signs of that. And that's what's responsible for the symptoms. The acne, the facial hair, oftentimes can contribute to irregular menses, higher BMI typically, although there is a lean PCOS syndrome, which is thinner women that don't ovulate regularly. But how does this all contribute to infertility? Well, they have the eggs there, they just don't ovulate them regularly. Many of these women will have insulin resistance and prediabetes, which is also not good for a pregnancy. The higher BMI patients, that adds in with the ovulation. There's a higher risk of miscarriage. And so the way we treat these disorders is one, lifestyle management, weight loss, diet, exercise, a supplement called inositol. And typically patients will undergo ovulation induction with a medication called letrozole to start. It's an anti-estrogen that helps to cycle patients and have them ovulate more regularly, combined either with natural intercourse or IUI.
Right, right.
And sometimes we'll treat them with metformin, which is a insulin sensitizing agent.
And another question which we often come across is for a person who's not familiar with IUI. IVF is something which all of us are familiar.
You've heard the term.
Yeah, which is pretty common. But IUI is something which we've not heard. So what exactly is IUI?
Yeah, I kind of call IUI the precursor or the entry-level fertility clinic or fertility treatment before IVF. So IUI stands for intrauterine insemination. So to backtrack a little bit, a patient comes to the fertility clinic or couple comes to the fertility clinic, gets their baseline diagnostic testing, checks their eggs, their fallopian tubes to make sure one or both are open, the uterine cavity is normal, and that the sperm is within normal limits or suitable for, let's say, IUI or IVF. So for a woman under 35 who's ovulating irregularly or semi-regularly or regularly, where the tubes are open and the sperm is relatively okay or mild male factor infertility, often a first step that's inexpensive, requires some monitoring, not as invasive, is medicated IUI. And so the goal of medicated IUI is really to bring more eggs and sperm close together to enhance the chances of pregnancy. And it is exactly that. So you're given some form of medication. It can also be within a natural cycle where either your one egg or multiple follicles ovulate. We track you to see when exactly you're ovulating with blood work and ultrasound. And at the time of ovulation, a sperm sample is produced or a sperm sample is thawed from a sperm donor, and the sperm is placed into the uterus through a small catheter that goes past the vagina, through the cervix, and into the uterus. And the way the procedure, the IUI, is actually performed is much like a pap test. You have a speculum put in, and we use a very small, tiny catheter to thread through the cervical canal and squirt the sperm close to the fallopian tube. So basically, we're putting the eggs and sperm close together right at the time of ovulation to enhance the chances of pregnancy. And so people always ask, how many cycles of IUI can you do? So it's really anywhere between 3 and 6 cycles. It depends on the diagnosis, the age, the quality of the sperm at the IUI, what the patient's tolerance level is to multiples if you're using medication and ovulating multiple follicles, how many kids you want, because if you're 38 and you're starting with IUI and you get pregnant and then you're coming back at 42 for baby 2, it's better to do IVF and have all your embryos.
Right. So that pretty much brings to my next discussion point. We talk about biological clock. Once women hit early 30s or even late 20s, there's always a question of when are you going to get pregnant, or the biological clock is
Of
ticking.
course.
And how does also women now, they're more independent, they want to, they're career focused. And so they push pregnancy towards late 30s or early 40s. So how does fertility change in 20s, 30s, and 40s?
Yeah. So, I mean, it is exactly the biological clock, what you said. So, women are born with a certain number of eggs. By the time they reach menopause at the age of 50, you only have about 100 eggs left, and those probably have multiple genetic abnormalities. So, once you hit puberty and you're fertile, obviously that's when the clock starts ticking. Every month you're losing eggs. And people always think, well, how am I going to lose that many eggs if I just ovulate one egg a month or if I take the birth control pill? And that's actually this is part of the myth busting. This is a myth that people think, okay, I'll take the pill and I won't ovulate that egg, so I'm going to have all my eggs. And that's actually not true. Every month there's something called gonadotropin independent atresia. And that's a fancy medical term to say all throughout your life, eggs are developing and undergoing atresia, which is just dying off. And so you're losing probably 15 to 20 eggs a month just due to the natural process of aging. So that number of eggs that you have essentially rapidly goes down over the course of your life. So between 20 and 30, there's not a significant drop, probably about 20 and 32. And that's probably why we say the ideal time to freeze your eggs is under 35. Between 28 and maybe up to 32, 33, you'll have the best egg quality of your life. After that, we see this shift where the antral follicle count, which is the follicle count, goes down, and you see a change every 6 months to a year. So that's not only quantity, but also quality. So the quantity drops, and as you get older, the chromosomal abnormalities in the eggs increase. So all the good eggs pretty much ovulate first, and you're left with this cohort of eggs where, as you get older, there's a higher proportion of genetically abnormal eggs. And so that's why the incidence of things like Down syndrome goes up dramatically over the age of 35. And so that's really what reproductive aging is. Women always ask me, they say, well, I'm still getting my period regularly at 47 years old. I must have eggs. You probably do, but there's fewer of them and they're more chromosomally abnormal. So the chances of getting pregnant with a viable, healthy pregnancy are significantly lower.
Right. So for a couple who's trying to conceive at 40, should they try naturally or should you just go for IVF straight away?
Well, remember, you're talking to a reproductive endocrinologist. So I would love if every 40-year-old couple came to me ASAP or even before they started trying for a baseline evaluation. And you'd be surprised. A lot more people are doing that right now, not only at 40, but at 35, at 30. As you said, women are delaying childbearing. And so a lot of them are like, okay, I'm going to start trying when I'm 35. That's just what I want to do because I need to pursue my career. We're getting our finances sorted out, whatever it is. And so they come to me at 34 and they do a baseline check, men and women, to say everything looks good. And then sort of to have a discussion. How long do you think we should try for before we come in and use assisted reproduction? And we kind of make a game plan. So I think that's really great because imagine if you're trying and a woman's 40 years old and you're like, okay, I'll give it 6 months to a year. Then you might be behind the 8 ball coming in at 41. But what is like the rule, let's say? At 40, we say, if you have regular periods and everything seems normal, you can try for 6 months. And if it hasn't worked at 6 months, come in and see a fertility doctor. But remember, if you wait the 6 months and you then get a referral, it might be 3 months before you get into a fertility clinic. So take that timeline into account. And nobody would fault you if you said, oh, I tried for 3 months and I'm 40 and I want to see you sooner. I welcome those consults.
Another question. Conditions like fibroids, endometriosis, thyroid, how do they affect chances of conception?
So fibroids and endometriosis, we kind of call anatomic concerns. They fall under the category of anatomic confirmed. So anatomic abnormalities. So let's unpack those one at a time. So fibroids are growths in the musculature of the uterus. So the uterus is a muscle. It's a big muscle. And so fibroids are basically little balls or growths of the muscle that are very circumscribed in the wall of the uterus. And they can be in multiple locations. They can be within the cavity of the uterus. So those are fibroids that are in the space where the embryo will grow. And they can be quite small, but still affect implantation and miscarriage risk. And so if we find one of those, oftentimes patients present with heavy bleeding, prior history of miscarriage. We'll have an abnormality detected on a uterine cavity test called the sonohystogram. Typically, those fibroids can be removed by a procedure called a hysteroscopy, where we take a telescope, look inside the uterus, and shave off the fibroid. Type 2 or intramural fibroids are in the wall of the uterus. So those fibroids, even if they're a little bit larger, if they're not affecting the inside of the cavity and patients don't have symptoms, then sometimes we can leave them alone. We kind of use the cutoff of like less than 5 to 6 centimeters or over 5 to 6 centimeters. And then there are subserosal fibroids. These are fibroids that are like under the skin of the uterus. So they're really kind of outside the uterus. So patients can have larger fibroids and sometimes not have any symptoms, and they can live with them and get pregnant unless they're blocking the tubes or kind of there's multiple fibroids distorting the uterine cavity. And it's sort of a risk-benefit, symptom-based. If they only have one embryo, we probably want to normalize the uterus before we put it in. So we kind of have a discussion about what makes sense in terms of removing them or not removing them. Endometriosis is a condition where the tissue that comes out during your menstruation goes through the tubes and kind of is like glue that sticks everything together in the pelvis. I mean, there's various pathogeneses. I've kind of told you the one of retrograde menstruation, but there's lots of different theories about how endometriosis forms. Some people think it's just development of endo from an immune dysregulation. There's so many different theories, but basically it's that you have this inflammatory condition where there's all this sticky menstrual effluvium all over the pelvis, and it can cause scar tissue. It can cause the tubes to have adhesions around them. It can cause dysregulation of folliculogenesis, which is growth of the ovaries. It can cause pain. It can cause lots of symptoms that are very untoward for patients. But more than that, it can also affect your ability to conceive. And the treatment of endometriosis, which is often hormonal if it's medical or surgical to remove the endometriosis, can also cause a delay in your getting pregnant or affect your fertility and your egg health. So it's actually a very complex medical condition. And I work closely with the gynecologist to sort of make a game plan for patients. So it's also the problem with endometriosis is patients often go like under the radar and they think, oh, this is just bad menstrual cramps. And they live with endometriosis for a very long time without getting diagnosed. So again, a little plug here saying if you have periods that you think are unbearable or are out of proportion with what they should be, please see a fertility specialist or a gynecologist or your family doctor. Get an ultrasound, see what could be going on, see a specialist, because if you have endometriosis, you shouldn't suffer in silence. And there's all this opportunity. Like today, I just saw a patient who has endometriosis who's going to freeze her eggs. So there's lots of opportunity to protect your fertility, get the right treatment, and optimize you before you get pregnant. So you asked about fibroids, endometriosis. Let's talk about hypothyroidism. So thyroid disorders and hyperprolactinemia, which kind of goes along with it sometimes, are endocrine disorders. So these are hormonal disorders that can affect fertility. Particularly hypothyroidism, is very common. And hypothyroidism is a particular endocrine concern that can affect the ability to ovulate regularly and can affect pregnancy and miscarriage risk, as well as fetal brain development. You don't want your baby to have neonatal or fetal hypothyroidism. So it's a very easy thing to check for. Prolactin abnormalities are also very easy to check for. It's just a blood test, a TSH and prolactin. And those are tests that we do in every patient who walks through our door because they're easily correctable and easily diagnosed. And so we usually say if you find hypothyroidism, hyperthyroidism, or hyperprolactinemia, treat that, normalize that, which can happen relatively quickly, and then try to conceive.
Right. So early diagnosis is really important.
100%.
Right.
Yeah.
Understood. And when we talk about eggs and sperm, how long do they survive in the body, and how does that affect for a couple who's trying to plan pregnancy?
Yeah, I mean, the fertile window is about 24 to 48 hours for an egg. Sperm can last in the reproductive tract for up to 5 days. So basically, if you kind of put those two things together, the fertile window is probably between 2 and 5 days. And so there's all these amazing apps, ovulation predictor kits, which are urine prediction kits that are very easy and relatively cheap that you can purchase even in the dollar store. And so for a couple who has regular cycles and they're overall healthy and they're young, under 35, particularly the woman, you can almost always start out with just cycle tracking. And again, like using an app is very simple. And so that'll sort of predict your ovulatory window and just have natural intercourse at that time. If you want to be uber careful, you can also use ovulation kits. There's other more savvy AI things like Mira Fertility, lots of other things that you can use. And they're really like easily accessible for patients who are pre-clinic phase to track their ovulatory window. But again, that doesn't tell you if you have blocked tubes or abnormal sperm. There are some companies, including our own Bird and Bee, that has a home sperm kit and a home ovarian reserve test. But again, these don't replace a visit to the fertility doctor that can look at everything. But I definitely think for a young couple who's like overall seems like everything is in check, to try with the apps, with the OPKs, as we call them, cycle timing and what we call timed intercourse is totally reasonable for starting out in the first 3 to 6 months. Right. And I mean, remember, you don't want to also take the fun out of it, right? So I think, as a fertility doctor, I'm not saying there isn't a place for just leaving caution to the wind and trying at home for a little bit.
Also, does monitoring basal body temperature and cervical
Yeah.
mucus, do they help?
I mean, historically, we learned about all this, but I think we have so many other great tests now, and basal body temperature and cervical mucus changes, well, everybody knows themselves, right? So I have patients who even now tell me about their cervical mucus changes even during a treatment cycle because they're worried they're ovulating. So I think that your personal sense of what your body's doing is really important, especially if you're trying at home. But would I say they're the most accurate way in the world to predict when you're ovulating? Not really. And basal body temperature only goes up after you ovulate. So you can kind of use that to say, okay, I need to try before that, but it's not as good at predicting your fertile window per se. Yeah.
People often wonder if arousal or using a lubricant helps with conception. So what does science say?
I think lubricants in general help in terms of the anxiety and the pleasure of intercourse, especially when you're doing it kind of on demand, right? But certain lubricants are toxic to sperm health. And so historically, we used to recommend mineral oil because it was the safest, but now there's a lot of lubricants out there that are marketed for safety for sperm health, and they're like readily available. So those are often a lot better choice, just to make sure that you're not using anything that could be toxic to the sperm.
Right. And there's a lot of information online about positions for getting pregnant. Is it true or is it just?
Yeah, I mean, I think patients will often say, oh, I felt the sperm leak out, right? And so what you're feeling leak out is not necessarily the sperm, it's just the seminal fluid, because sperm itself, we say sperm, but it's actually composed of the sperm themselves, which are microscopic and you can't see them, and a lot of other stuff like fructose and the seminal fluid, and there's so much other stuff in there. So the cervix is actually very good at accessing and catching that sperm. That's why the cervical mucus thins during ovulation, because it wants to let that sperm swim up past the cervix and up into the fallopian tubes. So, I mean, maybe an old wives' tale is that after intercourse, you just like lay down for a few minutes, but I wouldn't worry about the sperm sort of leaking out or falling out or anything like that. That's not a cause of infertility per se.
And if there's one message that you want to tell to a 25-year-old woman about fertility health, what will that be?
Yeah, I mean, I would say get checked early, know your body, and if there's anything that doesn't seem right, get it checked out. And a plug for egg freezing. I think, I think about my own daughters and I think about myself and my journey. I'm always happy to share this. I sort of fell into being a fertility patient in that I came new to Canada from the US and I was married, and I thought, I need to somehow start having kids and build a career in a new country. And those two things are like, it's like a Venn diagram that doesn't fit, right? And I think every woman out there faces this concern when you're in your 30s. And I was in my early 30s, but for a lot of women now, the age of first pregnancy is like mid 30s. So you're in your mid 30s, you're building your career, and you need to have a family. And so just being a fertility doctor, I fell into doing IVF sooner. And by doing that, I had extra embryos that allowed me to have a third child later in life. And so again, there was that whole thing on Instagram. If I were to have coffee with my 25-year-old self, I would tell my 25-year-old self, freeze your eggs, because you never know where life is going to take you. Right? And gone are the days when women, their top priority was only having kids. Now it's having kids, traveling, having experiences, doing stuff with your friends, your family. You have other responsibilities, obviously meeting the right person and planning that family. But think about it early. Be proactive. Be empowered. Like, this is your life. And we're lucky we're in this day and age where you can take charge of your fertility, whether it's just to get an early check, whether it's to say, listen, this is my plan. I'm going through medical school. I want 3 kids. This is my partner, but we're not ready to start now. What can we do to make sure this happens? Because that's all very possible and within your reach. And don't ignore anything your body tells you. If you think something's off, get it checked out.
Right. That pretty much brings us to the end of this episode. And fertility struggles aren't just medical. It's emotional, cultural, and deeply personal. And Dr. Sharma has broken down myths, spoken truth about miscarriages and stigma, and given us something which every couple needs: hope. So if you're listening to this episode and if you're feeling overwhelmed, please do understand that this is not a burden to carry alone. And reach out for help, because asking for help is the first sign of strength. And thank you. So I'll be sharing Dr. Sharma's details in the show notes, and you can contact her anytime. And thank you so much for watching this episode. Until next time, take care of yourself, and hope is never out of reach. Thank you so much.